Good afternoon. In this class, we talk about cardiopulmonary resuscitation. Cardiopulmonary arrest. What is cardiopulmonary arrest? Cardiopulmonary arrest means cessation of spontaneous and effective cardiac output, cessation of spontaneous ventilation. And CPR is we make an effort to provide artificial circulation and ventilation. Diagnosis of cardiac arrest is the patient is unconsciousness and apnea or gasping, and absence of pulse in large arteries. For example, in there is no pulse in carotid or femoral arteries, and the EKG may show ventricular fibrillation or electricity or mechanical saturation or ventricular statics. And the diagnosis of cardiac arrest, the time of diagnosis of cardiac arrest should be no more than 10 seconds. We review for most frequent causes. We say 6H, that is hypovolemia, hypoxia, and hydrogynia, and hypo or hyperkalemia, and hypoglycemia, and hypothermia. And another is 5T, is toxins, traumas, and tamponade cardiac or tension pneumothorax thrombosis, sometimes pulmonary or coronary thrombosis. And 5TS is also most frequently causes for cardiopulmonary arrest. This is the tract flow of the CPR. If you see the patient or some people, no movement, no responses, first is call for help, right? To activate the EMS, the first, right? If not response, check pulse. You can call, right? And check the pulse in the larger artery, for example, carotid artery or femoral artery, usually carotid artery, right? And then give chest compress and open the airway and check breathing, right? And if not breathing, give true breathing. This is the chart flow, the flow chart. And the components of CPR is basic life support. Usually start within 4 times. And this is airway, breathing, and circulation. And also advanced cardiac life support, and within 8 minutes. Specialized equipment to maintain airway, sometimes we give drugs and electricity defibrillation. And also post-resuscitation life support is more than 6 mean chest compression is associated with increased neurologic morbidity, and overall success rate is 10 to 20%. The basic life support usually give on spot and usually given by lay persons, and this is including diagnosis of cardiac arrest and activate EMS, right? And artificial circulation, open the airway, and artificial breathing. Common reason of the airway obstruction is tongue drops. You see the tongue drops. For this kind of situation, we usually give head tilt and the chin lift. This is head tilt and chin lift manuals, and open the airway, right? And or sometimes give jaw blast methods to open the airway, to give the mandible pulled forward, right, to open the airway. And if some foreign body airway obstruction, we say choking, we can give the abdominal thrust. This is HA recommended. And usually standing, the layby or layperson or the professional can standing behind the victim and first of one hand place between xiphoid and umbilicus, and also other hand grasp in the fist, right? Quick upward thrust, and this is kind of manual, right? And sometimes we can also we can give glycosylroidectomy to give the ventilation. And the breathing and the ventilation, exhaled air ventilation mouth to mouth, when performed properly, adequate alveolar ventilation can exist. And usually 16 to 17% oxygen can provide it, but it can cause gastric distension because of the high inspiratory pressure, high airway pressure. In the breathing ventilation techniques, one is head tilt, first head tilt and just lift and take a normal breath and seal the victim's mouth with lips and exhale. One breath over 1 second, and 2 breaths for every 30 chest compressions, and 2 breaths for every 15 compression if there are 2 rescuers and patient is younger than 8. Sometimes we can also give the mouth to nose or mouth to mask. This is mouth to mask. This is mouth to nose ventilation. And then breathing mouth to nose, usually because of the patient cannot open the mouth or cannot make a good seal, or sometimes severely injure the mouth or stomach distension, we can choose breathing mouth to nose. And mask ventilation, most common in ambulance and hospitals, and it can avoid contact between people, right? And can avoid the transmission of the infectious virus, and it can supplemental oxygen 40%, and it usually need 2 persons. And tracheal intubation mostly secure the airway. It is mostly secure the airway. We see it is also most stable airway and most effective. We can deliver 100% oxygen, and it is no stomach distension. It is its advantages. Need proper training, right? Need professional usage sometimes. And need instruments, and no need to pause ventilation when you give the tracheal and circulation. We say circulation, why the artificial circulation works, and what is the physiology for the artificial circulation. One is cardiac pump. We say when we give the artificial circulation, it is pressure of the heart between the sternum and the spine, pumping blood into the lungs and the aorta. And second one is thoracic pump. This compression causes the intrathoracic pressure to rise, forcing blood out of the chest. And 3 is distribution of blood flow. And the blood flow, total blood flow may be 10 to 33% when you give chest compressions. And nearly all blood is directed to the organs above the diaphragm, and heart perfusion about 20 to 50%, cerebral perfusion about 50 to 90%, and the organ lower the diaphragm, for example, abdominal and lower extremity less than 5%. And the gas transport, CO2 is accumulated in the tissue. Gas transport is not enough, right? Alveolar CO2 is low and arterial CO2 reduced. How to perform the chest compressions? This is the example. The techniques for the patient, for the victims, it is super, right? And on hard floor or on hard board. And the rescuer heel of hand over and parallel to the center of adult victim's sternum between the nipples, and avoid the xiphoid and the rib cut above the diaphragm, and kneel next to the victim's chest and shoulder over the hands. Depress victim's sternum at least 5 centimeters, and the frequency at least 100 beats per minute, and relaxation of sternum must be complete. Hands maintains contact with sternums. And how about the compression ventilation ratio? For a lay person, is 30 to 2, and for professional, a compression ventilation ratio is 30 to 2 is recommended, and further ventilation of guideline is needed. And for the infants, for children below 8 years old, and for 2 rescuers should use a ratio of 15 to 2. Once an advanced airway is in place, 2 rescuers no longer deliver circles of CPR. That is, compressions interrupted by pause of ventilation. That is, if you have two rescuers, and when the advanced airway is in place, when we give the CPR, it will not be interrupted by ventilation, right? And the rescuer delivering ventilation provides 8 to 10 breaths per minute, and the 2 rescuers should be change the pressure or ventilator rolls approximately every 2 minutes. And after give the CPR, we should recheck the circulation circle. And after 5 complete circles, about 2 minutes, check for signs of circulation for 5 to 10 seconds. If no pulse exists and no breathing, should continue CPR. During CPR, and we repeat again, should push hard, that is, sternum at least 5 centimeter displacement of sternum, and fast and more than 100 beats per minute, and ensure full chest recoil and minimize interruptions in chest compressions. When circle is 30 compressions, 2 breaths, and avoid hypoventilation. And secure airway and confirm placement after airway is secured. Continuous chest compressions, no pause for breathing, and 8 to 10 breaths per minute. Check rhythm every 2 minutes. rotate compressors every 2 minutes with rhythm checks, and search for and treat possible contributing factors. We already see 6H and 5T. We should find the causes and correct the causes. This is assessing adequate of circulation during CPR. For example, critical variables, right? Myocardial blood flow and aortic systolic pressure should more than 14 millimeter mercury, and coronary perfusion pressure should more than 15 to 25 millimeter mercury, and EtCO2 should more than 10 millimeter mercury. Another one is electrical therapy, and we should say electrical therapy is the most effective treatment and should not be delayed for drug administration. Sometimes we use AED for children between 1 to 8 years. Use a pediatric dose attenuator system for defibrillation. And for baby, use a manual defibrillator. And for adult, you can use AED, automatic external defibrillator. This is a device that monitors the EKG, and can recognize the ventricular fibrillation and charges automatically, and then give a defibrillatory shock automatically. When we give electrical therapy, and how much energy, it is differences between monophasic and biphasic. Monophasic is 360 J signal shock, and biphasic is 150 to 200 J single shock. And when the energy is too high, may cause dysrhythmias or myocardial damage or myocardial necrosis. So we should choose correct, proper energy for electrical therapy. During CPR, we should use drug therapy and establish of IV access. This is essential part of advanced cardiac life support. And peripheral IV, it is fast to place but delayed drug effects. And the central venous access is quick drug effects, but it's difficult to place. And the upper extremities preferred. And the other routine is intraosseous or tracheal tube. And usually we should open the upper extremities vein to open access, IV access, right? Commonly used drugs is below epinephrine, for example, 1 milligram single injection through IV, and every 3 to 5 minutes can repeat. And the vessel pressure 40 units, and may replace one or first or second dose of epinephrine, and also lidocaine and atropine and sodium bicarbonate and calcium, and we can choose and these drugs according to the conditions, according to the situations of the patients. This is algorithms of the BLS, basic life support, advanced life support. So this is basic life support. Performing basic life support, if the patient pulse needs arrest, and we just take. We check a rhythm and confirm if the patient is in the condition of ventricular tachycardia or ventricular fibrillation, and give a shock if available of the electrical therapy and its treatment, and then resume CPR for 5 circles, that is 30 compress and 2 breath, 2 minutes. And then you check the rhythm, confirm if there is ventricular tachycardia or ventricular fibrillation for the patient. If not shockable, for example, the EKG shows the heart is systoles or pulseless, and can go to give some drugs from the epinephrine and continue CPR and recheck. If you can confirm the patient suffers from ventricular tachycardia or ventricular fibrillation, continue CPR immediately and give one shock as defined earlier, and resume CPR after shock, and consider anti-arrhythmia drugs, for example lidocaine, and also continue 5 circles of CPR. If a patient is a systole, and when you do the basic life support, and you make sure the patient suffers from a systole, and resume CPR, 5 circles of CPR, and establish IV accesses, and give epinephrine 1 milligram, and can repeat every 3 to 5 milligram. Repeat every 3 to 5 min, and also you can give 1 dose of vasopressin, 40 units, and then can consider atropine 1 milligram, repeated every 3 to 5 minutes, and then you check the rhythm and confirm the rhythm. If shockable, you can go to ventricular and tachycardia or ventricular fibrillation algorithm. So that means you can resume the CPR, 5 circles of CPR, and give a shock. If shockable, you can give a shock. If the patient suffers from bradycardia, the heart rate less than 60 BPM and inadequate for clinical condition, you should maintain the airway and breathe and give breathing, give oxygen, and monitor EKG, blood pressure, SpO2, and establish IV accesses, and check if the patient have some signs or symptoms for poor perfusions. For example, if the patient has any acute altered mental status, mental disorders, or if the patient has any chest pain or hypotension or other signs of shock. If yes, prepare for transcutaneous pacing, because the heart rate is too low and the patient have some signs or symptoms of poor position. You should give the preposition for pacing, and use without delay for high degree block. You should use it without delay for high degree block. What is high degree block? That is type 2 second degree or second degree or third degree atrial ventricular block. And you can also consider atropine, right? You can give atropine, but sometimes there is no use for this kind of patients. And you can consider for epinephrine or dopamine. And when prepared the transcutaneous pacing, you can give the patient cutaneous transvenous pacing, and transvenous pacing and treated course and consultations. And if the patients have no signs and symptoms of poor perfusion, and you should monitor patient cautiously. Cardiocerebral resuscitation. You do the CPR. The purpose is to resume the function of the brain. You can imagine if the patient's heart is if the patient's heart works, but his cerebral function lost, it is very pity, right? So standard CPR survival rate are dismal. Only 10 to 20 success rate, and only 10 to 20% success rate is very low. And dealing with respiratory arrest and cardiac arrest not optimal for either. And cardiocerebral resuscitation (CCR) minimally interrupted cardiac resuscitation. 3 phases of cardiac arrest. Let us see. Phase 1 is electrical phases, 5 minutes about, and the intervention of prompt defibrillation. And phase 2 is hemodynamic phases, from 5 to 15 minutes. Intervention is generate adequate cerebral and coronary perfusion pressure. This is very critical for neurologically normal survival. So at this time, we should maintain the hemodynamic stable, should give the enough blood perfusion to the brain and heart. And the phase 3 is a metabolic phase, and more than 15 minutes. Intervention is applied hypothermia. Why we should do CCR? Hemodynamic response to chest compression is here. And survival rate after different CPRs. And you can see it is different, right? The CCR and CPR is more higher survival rate. And algorithms for CCR, it means pulseless arrest. EMS arrives, and you can give adequate bystander chest compression, and then you can chest rhythm and confirm the rhythm. And if shockable, you can give a shock, and secure airway, give oxygen. And you should open IV access and give 1 milligram epinephrine. And check a rhythm and confirm again. If not shockable, when you first time to check the rhythm and confirm the rhythm, if it is not shockable, for example, systole or pulse, you should give 200 chest compressions and open the IV access and give 1 milligram epinephrine. And secure airway and give ventilation and give oxygenation. And check the rhythm confirm, and also give 200 chest compressions. If shockable, for example, if the rhythm is ventricular tachycardia or ventricular fibrillation, you give second shock. You can give maximum output, then continue 200 chest compressions and ventilations, and also give oxygenations, and also can give second 1 milligram epinephrine, and then check the rhythm again. If it is not shockable, and also you should continue the 5 circle of CPR, and again the IV access ensure, and give epinephrine, and every 200 chest compressions plus 3 circles. and then you should secure airway and ventilation, and then check rhythm again. If shockable, you can go to the third shock, next output, and then 200 chest compressions, and ventilation, and give oxygen, and give third times of 1 milligram epinephrine. Last one is post-CPR care. Post-cardiac arrest myocardial dysfunction. Global, this is global myocardial stunning and can be mitigated with inotropics. And post-arrest brain dysfunction is cerebral ischemia and perfusion injury. After resuscitation, global sometimes have global hyperemia and prolonged global hypoperfusion occurred in brain and increased intracranial pressure or brain edema. And we should stabilize the oxygenation and the hemodynamics. For example, arterial PO2 should larger than 100 millimeter mercury, and PSO2 should less than 30 millimeter mercury, and HCT should maintain 30 to 35%, and the mean blood pressure should maintain 90 to 100 millimeter gram for better brain perfusion. Avoid hypoglycemia. We should maintain glucose and normal levels, and can give some drugs, for example, cypental or calcium blockers to protect the brain function. Protecting the brain, we can use therapeutic hypothermia, usually 32 to 34 degree and centigrade. Hypothermic on neurologic recovery after resuscitation from cardiac arrest due to the ventricular fibrillation over a period of 24 hours. And it means the degree of hypothermia is about 32 to 34 degree, and the duration of time is about 24 hours. And 50% in hypothermia group had favorable neurological outcome as compared with 39% in normothermia group. And 6 months mortality is 41%. And the international liaison community on resuscitation recommends unconscious adult patients with spontaneous circulation after out of hospital cardiac arrest should be cooled to 32 to 34 degrees centigrade for 12 to 24 hours within the initial rhythm as ventricular fibrillation. Such cooling may also be beneficial for other rhythms or in hospital cardiac arrest. That's all. Thank you.